आप
ही
मॉर्निंग
सर
वॉक के बाद यहीं बैठता हूँ।
सर 1 जनवरी से वो
Good
रनिंग
morning.
मोड में चल रहे हैं।
So, good morning, dear friends and respected faculty and dear delegates. It's time for the next session of the e-Pediatric ICU course. I request Dr. Maninder Dhaliwal to please start the proceedings.
Is Dr. Maninder available? He is busy
Yes,
in National Pediatric on.
Dr.
नहीं सर, अभी
Shamina,
हूँ भी
please,
यहाँ
would
पे
you
सर।
like to say
Okay,
something?
okay.
Dr. Shamina?
Welcome.
राइट
Nice
Dr.
to see you.
Shamina, please start.
Yes.
Hello, good morning, friends. On very warm welcome on behalf of Indian Academy Pediatric Delhi State. And today's we are the in continuation of the series. Today's we have the topic of life-threatening respiratory emergency. I would like to warm welcome our today's speaker, Dr. RASHMI Ranjan Das, as well as our moderator, Dr. Anil Sachdeva sir, and Dr. Sheikh Minaz Ahmad. Uh, Friends, I would like to introduce about the today's speaker. Dr. Das is a professor of the Department of Pediatrics, AIMS Bhubaneswar, and he has the trained pediatric pulmonologist as well as immunologist, and along with the allergy field, he did the wonderful job in their field in evidence-based research work. He had the large number of the publications, and he really contributed in the making the guidelines regarding the pediatric emergencies and pulmonology related field. Welcome to Dr. Ranjan, and over to Dr. Maninder.
It's a pleasure to have Dr. Rashmi with us. So we are going more interprofessional. So we have a pulmonologist and pediatric intensivist, Dr. Anil Sachdeva sir. He is a director at Division of Pediatric Emergency, Critical Care and Pulmonology at Sir Gangaram Hospital. Sir is a teacher of teachers. We are all students of Sir. Sir has led not only pediatric intensive care, but also pediatric critical care bronchoscopy. And he has umpteen number of publications in pediatric pulmonology and PICU. It's a pleasure and honor to have you here, sir, with us, moderating this session, because there are a number of doubts that the students have regarding emergency management, like dose of adrenaline, how to go about it. They'll ask you, they'll bombard you. You have to answer them, sir. And then none other than uh, the man, the senior, the people who look after is Dr. Sheikh Minaz Ahmed. He is leading the pediatric department and PICU department at Leelavati Hospital, Mumbai. Sir is written many textbooks, writing many guidelines, and he's actually a collaborating force between different chapters. So he is going to make this interprofessional growth something which is going to be seen in IIP pretty soon. So with that, I would request Dr. Rashmi to please carry on the presentation, and hopefully the students have many doubts, bombard and with the question and answers, and we have the experts and the best of the best to answer them. Over to Dr. Rashmi.
So thank you so much, sir. Good morning, respected chairpersons, all the dignitaries. So I'll share my slide now. So is my screen visible?
Yes, Dr. Rashmi.
Am I audible? Yeah. So today's topic is life-threatening respiratory emergencies in children. So these are the learning objective. So what I'm going to discuss today is the type of respiratory emergency. We have to identify whether the child is having respiratory distress, failure, or effortless tachypnea. How to approach a child with respiratory emergencies. Where to localize the pathology. It is very important that you should know where is the pathology so that appropriate treatment can be and timely treatment can be delivered. And then I'll discuss in the following subheading, like first I will discuss the upper airway emergency, then lower airway emergency, and some mixed emergency conditions, and finally some take-home message.
The voice is not coming, Dr. Rasmi.
It is not coming, sir?
Now it's clear. Can you be a little closer or louder?
Yes, sir. Yeah. So whenever a child comes to emergency, so first we have to measure the respiratory rate. So that is for a minute if possible, or you can just count it for 15 seconds and multiply it by 4. And then you have to look for the signs of increased work of breathing. So if there is increased respiratory rate, but there is a normal work of breathing, so this is known as effortless tachypnea, and it is classically seen in cases of poisoning, diabetic ketoacidosis, or there is renal failure. And if it is abnormal, there is decreased respiratory rate and decreased work of breathing. So both are decreased. So that means the patient is suffering from respiratory failure and he needs immediate attention. And if there is increased respiratory rate with increased work of breathing, then we tell it as respiratory distress. So it could be because of a myriad of conditions. It could be because of upper airway obstruction. Classical examples are croup, epiglottitis, foreign body tracheitis. And in lower airway obstruction, we have acute asthma, bronchiolitis, foreign body, and pneumonia. And lung pathology, if it is parenchymal, it is pneumonia, or patient may be suffering from ARDS, or there may be pleural pathology like effusion, pneumothorax, empyema. And we also have to rule out the cardiac pathology because they also present like some respiratory emergency patient will have tachypnea, respiratory distress. And if you don't examine properly, you may be misled by the presentation. So any child with attenuated congenital heart disease or some myocarditis, they also present with features of respiratory distress. And then we have disorder control of breathing, which could be central, secondary to any CNS pathology, like the patient has chronic status epilepticus, or there is a head trauma, and peripheral neuropathy, for example, GBS. So these present with disorder of control of breathing. So this is the broad overview of when you identify the child, you can classify if the child is suffering from respiratory failure, distress, or effortless tachypnea. And these are the examples. So another thing is that whenever a child presents to emergency, we have to see whether there is any features of airway obstruction. If it is present, where is the location? Because the location will tell you the clinical diagnosis and will help in delivering the appropriate intervention. So the obstruction can be at the level of upper airway. So how the child will present? The child will have stridor, which is marked. So classically, it is inspiratory stridor, but it could be also biphasic or respiratory stridor. So there will be increase in respiratory rate, but that is minimal. And when you examine the child, there will be suprasternal retraction. So that is that indicate probably the child is having some upper airway obstruction. Then if the child is having lower airway obstruction, they will have wheeze. And this type of wheeze is classically monophonic or polyphonic. So polyphonic example is asthma or bronchiolitis. If it is monophonic, so that tells that probably there is a kind of fixed obstruction. So in lower airway obstruction, the respiratory rate will be more compared to the upper airway obstruction. And here, instead of suprasternal retraction, the patient will have intercostal retraction and subcostal retraction. The patient may also present with pneumonia, severe pneumonia, or any kind of lung parenchymal disease. So in those conditions, patient will have grunting and the respiratory rate will be markedly increased compared to your lower and upper airway obstruction. Because whenever there is obstruction, the respiratory rate will increase, but to a lesser extent than to a parenchymal disease. And in parenchymal disease, patient will have intercostal retraction and subcostal retractions. So as I discussed earlier, sometimes the cardiac diseases and the pleural diseases like empyema, effusion, or this pneumothorax, they also will present like features of your lung parenchymal disease. So patient will have grunting, increased respiratory rate, and chest introing. And disorder control of breathing, what will happen? So there will be no noisy breathing. Okay. And the patient will have normal respiratory rate or bradypnea. And there will be pooling of secretions, and the patient will be in altered sensorium. And there is no retraction. So in disorder control breathing, you have to find that if no noisy breathing, no retractions, there is bradypnea. So probably the child is having some CNS problem. So by looking at the airway and in the previous slide, as I discussed, so you can broadly classify what is the syndromic diagnosis and how to approach the child. So when any child presents to emergency, we have to follow a uniform guideline. And there is no best guideline than the advanced life support. Okay, because it is a structured guideline. So that tells you how to approach a sick child. So the 3 steps all of us know we have to follow. The first is evaluate, then identify, then intervene. So EII. So what you have to evaluate? So when a child is coming to you, so first you should have the initial impression. So that is by the pediatric assessment triangle. Then you have to do the primary assessment. So that is by the pentagon ABCDE. Secondary assessment, so you have to take a focused history and do a focused clinical examination. And suppose you are not sure or the acute phase is over, so then you may have to do some diagnostic test to reach the diagnosis. So in identification, you have to classify the condition into whether the child is stable, and in respiratory condition, whether there is respiratory distress or failure. So it could be because of the upper airway obstruction, lower airway obstruction, lung parenchymal disease, or disorder control of breathing. So after that, you have to intervene, and again, you have to continue till the child is improved. So in the pediatric assessment triangle, we have appearance, breathing, and color. So in breathing, what are the things you need to see? So you need to see whether the child is having apnea or bradypnea or tachypnea, or there is stridor or wheezing, or there is a paradoxical kind of respiration, or there is respiratory distress in form of flaring of aleknasia or head bobbing. Okay, so that is in the pediatric assessment triangle, that is initial impression. So then you have to do the primary assessment. So primary assessment is ABCD. So in relation to the airway, so what you have to see? You have to see whether the airway is open, okay, or it is maintainable. So maintainable means we just positioning and clearing of the secretions, or with a nasal and oropharyngeal way, so the airway is maintained. And then you have to see whether it is maintainable or non-maintainable. So if it is non-maintainable, so how you know? So that means the patient will require some kind of advanced respiratory support. So you may have to intubate the child, you may have to put the laryngeal mask airway, or you may have to do the tracheostomy. So that is regarding the airway. So then you have to see the breathing. So in breathing, what you have to do? You have to see whether there is what is the respiratory rate, and all of us know the age-wise cutoffs. Okay, so in children up to 2 months, the upper cutoff is 60. 2 months to 1 year, it is 50. More than 1 year till 5 year, it is 40, and more than 5 year, it is 30. Okay, and then you have to see whether there is the bradypnea. So any respiratory rate less than 10 at any age is low, and it is bradypnea. And then apnea means cessation of breathing for more than 20 seconds, or earlier if there is some decompensation, like the child is having cyanosis, pallor, or the child is in shock. Okay, so that is regarding the respiratory rate. So then you have to see for work of breathing, then chest wall movement, and you have to auscultate the chest to look for any air entry, whether it is normal or decreased, or it is absent. So that will tell you also what could be the underlying pathology. And then any adventitious sound. So if there is stridor, it indicates there is upper airway obstruction. Wheezing indicates lower airway obstruction, and crepitation means that child is having asthma. So like that you have to see. Then you have to measure the oxygen saturation by the pulse oximetry. So this is regarding the breathing. So just to differentiate between respiratory distress and respiratory failure, because that is very, very important. So by the ABCD approach, you can differentiate whether the child is having respiratory distress or respiratory failure. So respiratory failure means immediately you have to do something, other than the child would die in maybe next few minutes or maybe few hours. So that is a real emergency. So how to differentiate? So if you look at the airway, in respiratory distress, it is open and maintainable. But in respiratory failure, it is not maintainable. So as I told, you have to give some advanced airway support like tracheostomy, or you have to do the intubation or laryngeal mask airway. So in the respiratory distress, there is increased respiratory rate with good air entry. But in respiratory failure, there is either tachypnea or there is apnea or bradypnea. And in respiratory distress, the circulation is maintained. There may be some pallor. And in respiratory failure, there is tachycardia or bradycardia or cyanosis. And in the disability, the child is irritable, anxious, and agitated. If he is having respiratory distress, the child is lethargic or unresponsive, is having a respiratory failure. And when you expose the child may be pale in case of respiratory distress, and cyanosis with variable temperature, you will find in respiratory failure. So by this ABCD approach, you can broadly classify whether the child is suffering from respiratory distress or is having respiratory failure. So let us discuss one by one. So first I'll be dealing with upper airway emergencies. So in this, one of the common conditions that we encounter is the croup. So in croup, it is also known as acute laryngotracheal bronchitis. So that is affection of the subglottic region. The classical age group is 6 months to 3 years. Most commonly it is caused by viruses, but please remember mycoplasma will cause atypical presentation. Okay, so it causes atypical croup. And diagnosis, it is mainly clinical, imaging is not required. So we know there is a classical stipple sign in croup, but ideally we should not do X-ray because it is a clinical diagnosis. So once you are having a child with croup, So then you can assess the severity by the Westlake Group score. And these are the parameters all of us know. And if the score is up to 3, it is mild. And if it is more than 6, it is a severe croup. So how to manage a child with severe croup, moderate to severe croup when the child is presenting to you? Okay. So in severe croup, there will be stridor at rest, retraction and distress, and the child may have hypoxia also. Okay. So in this condition, immediately you have to administer nebulized epinephrine. Dose is 0.5 ml per kg, maximum 5 ml. You have to make it, and the dilution is 1:1000. If you want, you can repeat after 2 to 3 hours. Okay. And please remember, there is no difference between this, our levo epinephrine and racemic epinephrine. Okay. So either of the two is good. So this levo form is available easily, so that we can use. And then you have to give the dexamethasone. The dose, single dose, classically described in literature is 0.6 milligram per kg. But people have seen that also 0.15 milligram per kg may act. And maximum dose is 10 milligram. Usually a single dose is given. That is enough. And because in croup there is airway edema also. So if you give dexamethasone, that will decrease. And the effect will last for 3-4 days. So by that time, it will relieve. And in some cases, suppose the patient is not responding, you can also use nebulized budesonide. The dose is single, it is 2 gram. You can try it. Is not a very common medication to be used, but in case-to-case basis, you can use. And you have to give oxygen if the child is hypoxic. Please remember, you have to administer oxygen by a non-threatening manner, and you should not irritate the child. If it affects commonly toddlers, so the child should be in the mother's lap. Okay. And you have to see that the hydration is adequate. So you may have to put the cannula and start the IV fluid also. So what are the indications of ventilation, mechanical ventilation or NIV in case of croup? So if there is exertion, the child is having worsening hypoxia, respiratory rate is more than 60 despite treatment, or it is falling, the child is having bradypnea without clinical improvement, or there is a normal or rising CO2. Okay, even normal CO2 in a child in distress is not normal. That means he is probably going into respiratory failure. So never take normal CO2 in emergency in a child with distress as normal. And while intubating, you have to keep something in the mind. It should be done by an experienced person. So you should not ask the junior one to intubate. And always use a ET size 1 millimeter smaller than the calculated size, because already there is airway compromise and it will cause more injury. You may face difficulty. Okay, so that you have to remember. So then epiglottitis, it is a disease almost which is now history. It may be like sporadic cases might be happening. The classical age group is 2 to 5 years. Previously, he was common, but now pneumococcal is the most common cause. So how the child will present? It is an kind of acute onset. There will be high fever, sore throat, dysphagia, muffled voice, and the child will prefer to sit in the tripod position. There will be drooling. But please remember, in epiglottitis, there is no cough. So in croup, the patient will have barking cough, okay, which is prominent. But in epiglottitis, the child will not have cough. So again, it is a clinical diagnosis, and we should not try to examine the airway because it will kind of precipitate airway obstruction. So how to manage these cases? So airway stabilization, the priority. Intubation is often necessary. You have to do in the control setting. You may have to ship the patient to the ICU. You have to take the anesthesia consultation. Everything should be ready. And you also have to be ready in case of failed intubation to do the cricothyroidectomy. And once the airway is secured, you have to give the IV antibiotics to cover the organism. So then bacterial tracheitis. Okay. So it is a severe infection of the circulatory region. And there is airway edema, along with there is a pseudomembrane formation. Okay. And the classical age is around 3 years old, and it peaks in winter. The mortality is high if you are not recognizing it early and treating it early. And etiology, it is mostly polymicrobial, a combination of Staph aureus, pneumococcus, HIV, and Pseudomonas. Sometimes Borexella also you can find. And usually it starts with a mild URI, and suddenly the child will progress to develop high-grade fever. There will be toxic look. And the child usually presents with features of airway obstruction like stridor, tachypnea, retraction. And there will be wheezing, which is classically monophonic. Okay. And diagnosis again clinical. And you may do the lateral X-ray. And so you will find subglottic narrowing along with the tracheal narrowing because of the edema. Okay. So that is in contrast to your croup. And if you do intubation, you will find that the epiglottis is normal. So epiglottis normal, you are not finding anything. And the sublet region, you are finding pause formation or edema. So that tells that probably the child is having a bacterial tracheitis. So how to manage? Keep intubation ready. Again, the tube size should be 1 millimeter smaller. The patient may have to be shifted to PICU if you don't have facility of SDU. And you have to give empirical antibiotic that should cover the MRSA. And toxic shock syndrome. This is one of the common complication. So that's why any child with bacterial tracheitis, always have a look, because anytime the patient may go into shock. So then diphtheria, it is also nowadays rare. We are seeing very few cases. You might be also seeing very few cases, but it is an important condition that can be life-threatening, and it is a bacterial infection. So the patient will have sore throat with membrane in the tonsillopharyngeal area. So if you see this image, in tonsillitis, you see there are some pause points, okay, which is very irregular. But in diphtheria, we will find a very kind of thick membrane, which is whitish or sometimes yellowish, and it is over the pharyngotonsillar area. Okay, it is a very single one and very thick, in contrast to a tonsillitis, because many times you may get confused with the tonsillitis. So how the child will present? The child will have fever, hoarseness, barking cough, and stridor. So if you see the clinical picture, it may mimic that of the croup also, and epiglottitis. And suppose the child is presenting late, after a few days, you may not be able to find any membrane. So when there is no membrane, please do not think that the child may not have diphtheria. So in late presentation, the membrane may not be there. Or the child may present with acute neuropathy, myocarditis, or respiratory failure directly to you. So how to diagnose? So take a throat swab, send for Albert stain. The lab will give you the report within 30 minutes. If it is positive, then it is diphtheria. You may send for culture or PCR. So you have to admit the child, put the child in the isolation, give the supportive treatment, take care of the airways, take care of the hydration. Antitoxin you have to administer, because without antitoxin, the patient may not respond actually. Okay, so that is a must. And the dose is variable, but in severe cases, 80,000 to 1 lakh unit you have to give. And antibiotics, you have to choose ceftriaxone, penicillin, and in penicillin allergic cases, erythromycin. And if there is respiratory failure or airway obstruction, you have to intubate again in the control setting. So any patient with the upper airway obstruction, like as I discussed, so have to be intubated in a controlled environment with keeping everything in background. Okay, in case there is a failed intubation or anything, and a person who is experienced in intubation should try. So retropharyngeal abscess, it is not a kind of upper respiratory disease, but it will affect because that area is very closely close to your upper airway, okay, trachea, and it is not rare. We also see 1 to 2 cases per year, and it is a severe condition, and if not detected early, the mortality is very high. And classically, it presents in the toddlers we have seen around in children around 3 to 4 years of age. And etiology is very peculiar. So group A, beta hemolytic streptococcus, it is the most common organism. Then you can have Staph aureus and anaerobes. So how the child will present? So child will present with high fever. There will be limited neck movement. There may be torticollis. Okay. Again, a patient may have muffled voice, dysphagia, drooling. So these are the red herring. Okay. So whenever any muffled voice, dysphagia, drooling is present, you have to think of these conditions as I discussed: epiglottitis, bacterial tracheitis, then your retropharyngeal abscess. So you have to keep these things in mind. Diagnosis. So if you do a lateral X-ray, as you can see in this X-ray, so there is an increase in prevertebral space. Okay. And you may have to do the CCT. And why? Because in CCT, if there is abscess, you need to drain it, because this is the area which is very vital. And if there is abscess, it expands, it will compromise the airway. So that's why you have to do a CT or ultrasound on neck to see if there is any abscess formation. So always take a ENT consultation, shift to PICU, airway obstruction is present. You may have to give empirical antibiotics to cover both streptococcus and MRSA. And surgery if there is abscess or there is a airway obstruction. So then coming to the lower air emergencies. So in lower airway emergency, we have bronchiolitis. So it is a viral lower respiratory tract infection classically seen in infants. And the most common age group is 2 to 6 months. And so what happens in bronchiolitis? So the small airway is affected. So there is airway edema, mucus plugging, then airway obstruction and airway air trapping. Okay. And how the child will present. So initially there will be some URI features like some running nose, mild low grade fever. After that, the child will develop severe respiratory distress, in form of tachypnea. There may be chest indrawing, head bobbing, and there may be hypoxia. And small infant, they may also present with apnea. So this is the classification of grades of bronchiolitis. So in severe, because we are dealing with life-threatening cases, so the child will have severe respiratory distress, respiratory rate of more than 70. Okay. So any respiratory rate more than 70 in infants less than 1 year or more than 50 in more than 1 year indicates there is severe respiratory distress with or without chest indrawing. And saturation of less than 90% in room air or apnea, or if the child looks unwell or toxic. So these are the features of severe bronchiolitis. So it is a viral disease. So management is supportive. You have to give oxygen, maintain hydration, antibiotics, shift to PICU in severe cases. And salbutamol, you can give a single dose and see. Because sometimes the patient may present with even severe allergic airway disease. Okay. So if the patient is responding to salbutamol, then only you continue. If the patient doesn't respond, then just stop there. So 3% saline, it is also not routinely indicated. It is indicated in case of moderate to severe bronchiolitis. The dose is 3 to 4 ml. So you have to give a trial. If the patient is responding, you continue. If the patient doesn't respond, you may stop it. There is no role of antibiotics and steroids. And moderate to severe cases particularly benefit from your heated, humidified, high flow nasal cannula, or sometimes from the NIV, like the BiPAP or the CPAP. Okay. So HFNC is a very good modality of respiratory support in bronchiolitis. And you can save many children by employing this method, particularly in moderate to severe cases. And if the patient doesn't respond, is having progressive distress or respiratory failure, you have to put the child on mechanical ventilation. So then we have acute severe asthma. So it is allergic airway disease. So whenever a child presents to the emergency, there are many scores available. You can do the PRAM score, or there is a pulmonary score, which is comfortable to you, that you can do, because all will tell you the severity. And in PRAM score that is commonly used, we have to look for the suprasternal indrawing, scalene retractions, wheezing, air entry, and room air oxygen saturation. So then you have to score, and if the score is 8 to 12 PRAM score, then it is a severe or life-threatening asthma. So then drugs, what are the drugs you have to use? So salbutamol, you can use by the nebulizer. The dose is 0.15 milligram per kg per dose. 3 doses you have to give within a manner and see the response. Or else if the patient is using MDI, you can use MDI with spacer 4 to 8 puffs every 20 minutes. Okay. And then you have to give ipratropium bromide. The dose is 0.25 to 0.5 milligram every 20 minutes. Then maximum up to 48 hours you can give. And corticosteroid, of course, you have to give the patient is able to take orally, give oral prednisolone 1 to 2 milligram per kg start dose. If the patient is not able to take orally, then IV methylpred 1 to 2 milligram per kg, or hydrocot you may have to give. Okay, dexamethasone you can give. So there is no difference, much difference between different types of steroids. So if you are comfortable with them, you can give. Then oxygen therapy, of course, if the patient is having hypoxia, to maintain saturation more than 92%. And suppose the patient is not responding, you may have to use the magnesium sulfate. Dose is 50 milligram per kg. Maximum to the dose of 2 gram you can use. And if you want, you can repeat after 6 to 8 hours. Okay. And suppose the child is still not responding, you can use epinephrine. It is subcutaneous or intramuscular route, never IV. Dose is 0.01 milligram per kg. And helium plus oxygen mixture, that is Heliox, you can use, but it is not available. And suppose patient is not responding, you can use aminophylline or torbitalin infusion. Torbitalin is not available. So aminophylline infusion you can use, and you can shift the patient to PICU if the patient is not responding. And once the patient is in HDU or your PICU, so you have to give advanced respiratory support if required. So again, heated, humidified, high flow nasal cannula you can give if there is persistent hypoxia despite oxygen. NIV you can try, but you have to be careful because the patient may blow a pneumothorax. And if the patient is going to respiratory failure, you have to intubate. And so once you intubate in ICU, so these things you have to keep in mind. Use ketamine for induction. Why? Because ketamine is a bronchodilator, so it will help. And then in ventilation strategy, so you have to adapt certain ventilation parameters like low tidal volume you have to use to avoid air trapping, because already there is air trapping. Otherwise, I will blow a pneumothorax. So low respiratory rate just to allow full exhalation, and permissive hypercapnia. Okay. So to avoid aggressive ventilation to prevent barotrauma. So these are the classically described ventilation strategy that has to be used if the patient develops respiratory failure. So then we have severe or very severe pneumonia. So that is, in fact, this is the most common life-threatening emergency we see. Patient will present with lethargy, poor feedings. There may be cyanosis, severe distress, apnea or bradypnea. Patient may have altered sensorium. Okay. So immediately hospitalize, give oxygen. You may use all those modalities I discussed like HSFNC or NIV. You have to give appropriate antibiotics, send investigation, do the X-ray, and rule out complicated pneumonia also. Please remember there is no role of steroid. Steroids are useful in adults with severe or very severe pneumonia, but not in children. So there is no role of steroid. And admit to PICU if the patient is not responding, or there is imminent respiratory failure, or there is sepsis or MODS. So pneumothorax, so again, it is a life-threatening emergency. The causes could be trauma, either chest or barotrauma if the patient is on ventilator, or non-traumatic. There may be a hidden apical bleb or bulle that has ruptured. There may be genetic predisposition. Sometimes it may develop spontaneously or secondary to asthma, foreign body, or underlying lung disease. Okay. So how the child will present? So child may have sudden onset pain, which is worsening on inspiration. The child will have breathlessness. And when you examine the child, there is decreased chest expansion. The chest is hyperresonant. Or if it is tension pneumothorax, the patient will have respiratory failure. The patient may have shock also. Or if the patient is already on ventilator, there will be increased ventilator requirement. So if you do X-ray, so this is the X-ray of a tension pneumothorax. Okay, on the right side, so you will get mediastinal shift, and the affected hemithorax is totally darkened. So sometimes bilateral pneumothorax is difficult to detect because your air entry is bilateral decreased. So it may be difficult. You can also do bedside transfibrillation test that will also detect pneumothorax. If the patient is not you are not able to see the patient to emergency, or if you don't have the facility to do a bedside X-ray. Okay. So diagnosis, if already the patient is in tension pneumothorax, okay, features of decompensation are present, immediately proceed to needle aspiration without doing any X-ray or other investigation. If the patient is stable enough, you can get a chest X-ray that is done in upright position, because supine X-ray will miss the pneumothorax because the air will be collected anteriorly. Okay, if it is a small pneumothorax. So better to get a upright chest X-ray. Or you can get a focus. Okay, so nowadays ultrasound is available also in every emergency and ICUs. So that is both diagnostic and therapeutic. You can detect the pneumothorax. So how the pneumothorax will appear in focus? Okay, so there will be absent long sliding, and the curly B lines will be absent. Okay, and it is therapeutic because you can put ultrasound guided even tube thoracostomy. Suppose it is a large pneumothorax. So that's why focus is preferred if it is available over the chest X-ray. And how to manage? So if it is a small pneumothorax, the size is small. Okay, at the higher level. Okay, you have to measure the size. So then you give oxygen high flow, so it will gradually resolve. At the same time, you have to take care of the underlying condition that has led to pneumothorax. And if it is a large one, or there is failed needle aspiration, or in spite of giving high flow oxygen, still it is not resolving, you may have to put the chest tube. And if the underlying lung is abnormal already, okay, you feel that the lung is abnormal, already there is a risk, or there is something that may again blow a pneumothorax, it is better to put a tube thoracostomy prophylactically. So then some mixed emergencies. Okay, so among the mixed emergency, the most common emergency we encounter is the foreign body aspiration. Okay, so it is very rare in small infants, but we have seen in infants of even as low as 6 to 8 months of age. Okay, sometimes while feeding, parents might have accidentally put something in the airway. The child might sometimes aspirate, not voluntarily. But if the child is more than 1 year or toddler, so they usually put everything in the mouth. So there is a high chance of foreign body aspiration. It is rare in older children, but sometimes you may find also. And right main bronchosis is the most common site. Why? Because it has a longer course, and it is narrow, and it is a vertical orientation. And when it starts from branching from the trachea, what will happen? So the osteum is narrow. So once it enters, the foreign body will not be able to come out, even if the child coughs. So that is the most common site of dislodgement. And the presentation or severity will depend upon different factors. The first one is size and shape. If it is a rounded object, it may cause the complete obstruction. So the child will present with apnea or respiratory arrest. Okay. And location, it could be laryngeal, tracheal, or bronchial. Okay. So if it is a laryngeal foreign body, so child will present with one of those features like it may mimic as a croup because there will be stridor and the voice change may happen also. And if it's a tracheal foreign body, again, it is dangerous. So child may develop respiratory arrest. And if it's a bronchial foreign body, so child may present with distress. And when we examine the child will have decreased air entry or absent air entry on that side. You may get monophonic wheezing. Okay. And degree of airway compromise will also decide the severity. If it is a partial one, the child will present with distress. If it is a complete obstruction, child will present with respiratory failure. Okay. So these are the X-rays of some common foreign bodies in our setting. Okay. So if the child is stable enough, you do a X-ray. Otherwise, you have to directly proceed for advanced investigations. Okay. And foreign body aspiration may mimic bronchiolitis asthma. So if the child is stable enough or there is a history of receiving nebulization without any response, always think of a foreign body. Okay. And there are some mobile foreign bodies that usually travel to both lungs, like suppose it is on right side, it is go to left, like that. So in those cases, the findings might change also, so you have to be careful. So this mobile foreign bodies have been described in literature, and you have to immediately remove them because as they are mobile, sometimes suddenly they will travel to the upper airway and they will block the trachea and the patient may die also. We had one child with whom we had a bad experience. So there he came in the night, and we are waiting because the pediatric surgeon told that at that time we didn't have bronchoscopy facility. We have to depend upon rigid bronchoscopy. The surgeons saw the child. They are telling, they told that the child is stable, nothing to worry. We'll do rigid bronchoscopy in the morning. But the child passed away in the night. Suddenly, he developed respiratory arrest and he died. So you have to be very careful. And whenever you find any foreign body, immediately you have to try to remove if it is acute case. Suppose it is a chronic case, it is dislodged or it is causing recurrent persistent pneumonia, then you may take your time to remove it. So management, you have to provide first aid, follow the ALS guideline in infant and children. If it is infant, that is less than 1 year, so you may have to give 5 blows and 5 chest thrust. Okay. And if it is a child more than 1 year, you may have to do the Heimlich maneuver to remove the foreign body. So that is the first aid. Okay. So if the child is having respiratory arrest or is not able to breathe. And after that, as I told, so immediately you have to do bronchoscopy if you have the facility, or you may have to take the help of your colleagues like ENT or adult pulmonary medicine people or pediatric surgeons. They usually do the bronchoscopy if you are not doing. And in all cases, please remember, you have to go for bronchoscopy. It could be flexible and rigid, but the rule of thumb is that you can do flexible, rigid combined, because in flexible, you can localize the foreign body, and in rigid, you can remove actually. Okay. But suppose the patient is presented with respiratory arrest, is not breathing, you have intubated the child. So then it is up to you whether you are going for rigid bronchoscopy or you are going for flexible also. Okay. Because rigid bronchoscopy, foreign body cannot be removed from the distal airways. Okay. So that's why if you do flexible, you can easily localize the foreign body. There is no role of chest X-ray or CT scan. Many a time we see that the patient has come up with a chest X-ray or CT. They don't basically tell you what is going to happen. Okay. They may localize, but it is of less importance. So never do a X-ray or CT unless something is in doubt. Patient is stable. You are not able to know what has happened in those cases, but in emergency, don't wait for the X-ray or CT. And if there is severe obstruction or there is a failed removal, you may have to intubate the child. So then anaphylaxis, it is a severe life-threatening IG-mediated systemic reaction. how it is diagnosed. So it is diagnosed based on one of the following. There is acute onset within minutes to hours of a severe reaction involving skin or mucous membrane. There may be hives, angioedema, or flushing, plus either respiratory symptom like wheezing, dyspnea, or stridor, or cardiovascular collapse like hypertension or syncope. Two or more of the following after allergen exposure like skin or mucosal involvement, respiratory compromise, hypertension, or GI symptom, or hypertension after exposure to a known allergen. Because anaphylaxis, most of the time it is missed. You do not know what has happened. So if you remember these clinical features, you can easily identify. And it is a life-threatening emergency. Immediately you have to administer the medication. And the epinephrine is the life-saving medication. It is used in a dilution of 1:1000 intramuscularly, not intravenously. Okay. So in the anterolateral thigh, you have to give, that is the vastus lateralis muscle. The dose is 0.01 milligram per kg, and maximum dose is 0.5 milligram per dose. You can repeat every 5 to 15 minutes if symptom persist. So then you have to give oxygen. If the patient is in shock, you have to give crystalloids, and you may have to give beta-2 agonist, antihistaminic like diphenhydramine, H2 blocker. Sometimes some people they give, and steroid to prevent delayed or biphasic reaction. So prednisolone or methylpred you can use also. So please remember, after the acute episode is over, observe the child for at least 4 to 6 hours to monitor the biphasic anaphylaxis. So the second episode may happen. And if the symptom is recurring, you have to hospitalize. And when you are discharge with oral antihistaminic plus steroid for 2 to 3 days. Okay. And you have to give specialist referral just to know why it has happened. The child may have something, so that need to be diagnosed. So then we have injury secondary to toxin or drowning. So here the most commonly it is acute onset. The patient may present with respiratory distress or failure. The common presentation that the patient may present with sudden onset of ARDS, pulmonary edema, chemical pneumonitis, atelectasis, or lung fibrosis also, particularly in case of paracord poisoning. And management, it is mainly supportive. So you have to take care of the airways and ventilation, oxygen, then advanced respiratory support you have to provide. And if the patient is respiratory failure, you have to give mechanical ventilation. And there may be some antidote if you know the toxins. Like, for example, methemoglobinemia, you may have to give methylene blue or vitamin C. So it is not a respiratory emergency classical, but the patient will present with hypoxia. Like if you're measuring oxygen saturation, it is low, but your PaO2 is very high. The child may have cyanosis. So in those cases, you can use the antidotes. Okay. I didn't discuss the disorder control of breathing. So in those cases, patient will have, as I told, there will be patient may have apnea, bradypnea. There is difficult to maintain the airways. There is drooling of secretions. So if you examine the child will have features of your CNS involvement. So in those cases, you have to take care of the airways. The patient will require advanced respiratory support, may require intubation if the GCS is less than 8. You have to take care of the secretions, and you have to take care of the primary disease. So if it is GBS, naturally you have to give the definitive treatment. Or if any other respiratory CNS disease, you have to give the definitive treatment. So that is regarding the disorder control of breathing. So with this, we come to the end of the presentation. So common life-threatening respiratory emergencies in children are asthma, croup, bronchiolitis, pneumonia, and foreign body inhalation. Emergency clinicians must stay updated on current guidelines to optimize care, avoid both underuse and overuse of therapies and diagnostic tests. Clinical practice guidelines provide evidence-based recommendations. We have to follow one. So whenever we are approaching any child, it is better to follow ALS guideline and your society guidelines. And there should be ongoing education training for emergency clinicians, because if you are not educating yourself and keeping update with the current evidence, so you may fail in managing a child with life-threatening emergency, because life-threatening emergency will not give you a second chance. So thank you so much for your patience hearing. If there is any doubt, we can discuss. I think I have finished in time.
Yes, sir.
Thank you, Dr. Rashmi, for a wonderful presentation.
Wonderful.
I think this is one of the most common emergencies, respiratory system emergencies. Please, I request the chairpersons for their comments.
Beautiful, Dr. Rashmi. We loved the talk. It was very clear. Messages were very clear, but we have tough questions. So I request the moderators. I'll ask the question to the moderators, and then you can also chip in.
Yes.
Dr. Anil Sajde, sir, the $1 million question. Astelin versus Levolin. Which one do you propose and why?
Astelin versus Levolin, both are, they are real brothers. They are twins, so you can use either of them. It doesn't matter. It doesn't matter at all. Only the cost, little bit difference in the cost factor is there. Otherwise, utility-wise, they are same.
So what do you use, sir, in your unit?
Whatever is available in the emergency, but
And
must use. You must use.
you must use. Perfect, sir, perfect. And then comes the second question, sir, about duolin versus hypertropium, sir.
Duolin is a combination of beta agonist and ipratropium bromide. So it is not the first line treatment that I would use in the acute wheezing, like asthma situation. I will use plain beta agonist 3 times back to back, and then if there is no response, then maybe because the ipratropium bromide is a very minor role in the management of acute asthma.
And so there's one doubt. So when they start hypertropium bromide, till what date or day should they continue? 2 days, 3 days?
It usually loses efficacy in 2 to 3 days. So after 3 days, definitely there's no role.
Perfect, sir. Clear answer, sir. Thank you for that. Now the question is for Sheikh, sir. Sir, they are asking the methylprednisolone in asthma. Should they give an emergency itself if they are thinking the patient is not improving with the first dose of NAP, silbutamol? Or what is the right time to give the methylprednisolone IV or oral hydrocort or prednisolone?
Well, the latest guideline says earlier we do the better. In fact, it is said if you say defined asthma in a case who has been like previous episodes also, you can start from the home only. You can give the first dose at home of the oral prednisolone and then come to the ER. So if it is a known case of asthma, then it is desirable to go earlier, whatever is available. That's the bottom line. The second is what is to be given, oral versus parenteral, injectable. The bottom line is whatever can be given early. If it is in ER, of course, injectable. The next question, the main important question is what is to be given? Methylprednisolone versus hydrocortisone versus dexamethasone. This has often been, a problem with the journalist and the intensivist. Intensivists generally prefer methylprednisolone. However, hydrocortisone also can be given, and dexa in some cases. I would like to have the opinion of the Anil Sachdeva sir about the use of dexamethasone in acute care. Like we have been trained and told about the methylprednisolone and the hydrocortisone. So we prefer.
Sheikh, I belong to hydrocortisone era.
Yeah.
We used to give hydrocortisone bolus and then followed by 5 milligram per kg every 8 hourly for 3 to 5 days. But as you have rightly said, whatever is available you give. Earlier you give, it is better. It can be given if it is a known case of asthma and you get a phone call when my child is having acute asthma attack, then whatever they have, even most of these patients, they do have prednisolone tablets at home, so they can give at home and come to the emergency. In emergency also, if the patient can take orally, you can give oral also, you can give injectable also, but the steroid is required for the management of moderate to severe asthma.
So what about dexamethasone? People still try to use dexamethasone, low dose, medium dose, high dose. I mean, there's always been a debate. We are clear about MPS and hydrocortisone.
Dexamethasone dose is, I think, 0.5 milligram per kg per dose.
Would we use that in the acute care, sir, acute asthma? Because it is, of course, it is a long-term effect. But we want immediate effects. And the immediate, you rightly said, hydrocortisone and MPS, methylprednisolone.
If in the emergency the Dexa is only available, then you have no other choice.
Yes.
If you have choice, then you prefer to use methylpred or hydrocortisone.
Okay.
Yes,
so I'll ask a difficult question to Rashmi because there's a problem in dosages. So if you open Harriet Lane, it says the dosage of hydrocortisone is total of 10 mg per kg per day. And if you read other books, then they say 5 mg per kg per dose TDS to QID. So Rashmi, what is your take on that? Which dosage should a student follow? Because there's a controversy about hydrocort dose.
Yes, sir. So I will agree. Both are respected experts. So whatever is available, you have to use. So there is practically no much difference in the efficacy of different type of steroid. So now coming to the hydrocort dose. So classically, what we have been taught that you have to give a bolus, then use it every 6 hourly. But books tell that you have to use a dose of 2 milligram per kg. Some tell that up to 5 milligram per kg. So classically, what we use is around 2 milligram per kg per dose every 6 hourly. So that is the
So you
dose
make
we.
it 10 mg per kg per day.
Yeah. So
Maximum.
up to that you can use. And sir was telling 5 milligram per kg. If you want, actually, there is no head-to-head trial, so very difficult to tell. But the common dose what we use is around 2 milligram per kg per dose every 6 hours.
Thank you. Thank you for clarifying, because many of the units still follow that 5 mg per kg per dose, then TDS. But it's not wrong to use that also.
Yes,
Then,
sir. Yes, sir. So there is no head-to-head trial actually. So it is based on your unit practice and experience. If you are feeling that okay, it is working, it's better to continue actually.
So the question is to Anil sir. Sir, there is a question that hypertropium, is there an age restriction that below this age there is no role?
In infants, they say usually it doesn't work well. But again, I'm saying, I mean, why our students and the delegates are so much on hypertropium? It is a very minor role, so it can be used, but in very small infants, it may not work because of the lack of the muscarinic receptors.
Correct. So mostly the disease would be bronchiolitis, and there it has no role in less than 1 year.
Yeah, and
I
Maninder, essentially
In
it is.
bronchiolitis, there is no role for hypertropium. I'm sorry.
Correct.
There is
Correct.
no role for hypertropium in bronchiolitis.
I'm saying that's why sir, people should not use it, because most
Yes.
common respiratory distress is bronchiolitis in an infant.
And
Uh,
Maninder, it is, essentially with regard to asthma, I think we should focus more on the beta agonist, number one. Number two, early institution of steroids, oxygen support, hydration, and the important thing is early use of magnesium sulfate. Early use of magnesium sulfate, which has come up in a large way. I have seen people still hesitant of using the magnesium sulfate in ER. And sir will also agree, early bringing of magnesium sulfate really bring change. In an early phase, it is really helpful.
it's a very safe drug to use in the ER also. In ER, we all have cardiopulmonary, cardiorespiratory monitors. So just connect the patient to monitor and give magnesium. It's a very safe drug, and it has been proven in
So
PGH
just to
Chandigarh
clarify,
trials. Yeah.
IV drug, the IV magnesium we are talking about, not
Yeah, I'm
nebulized.
talking
Yes.
about IV
No, no,
early
no.
bringing of early magnesium. Yeah.
IV magnesium.
IV,
And
IV,
secondly,
IV.
sir, there's always with the magnesium sulfate, there is always a fear that it will cause hypotension. I think all of us will agree that in a therapeutic dose, it does not.
The one single dose will not cause it. Maybe if you give TDS or an
It
infusion,
is
the
single
risk
dose
increases.
only.
Yeah,
It is single dose only. You can repeat it after 4 hours if you
4
need to.
hours. And it is
Sir,
really
actually,
helpful.
Sir, actually, the old GINA guideline, it was mentioned nebulized Maxal, but a systematic review was published from AIMS Jodhpur, after which the GINA changed. They omitted nebulized Maxal. So we should not use nebulized Maxal.
In fact,
Only
we
IV.
are always using Rashmi
Yes,
will
sir.
always using the injectable magnesium
Yes,
sulfate.
sir.
And
Yes.
sir, our practice is to bring us magnesium sulfate early in the ER, and it is really useful, sir.
Yes, sir. Yes.
Okay, now one more important question, because many of the pediatricians ask this. What about nebulization versus MDI at home? I would ask Dr. Anil Sachdev, sir, what do you advise your parents, or as per age group, that nebulization at home is okay or can be given with and without oxygen? Anil sir.
Yes, we can give in the starting point, we can give nebulization or MDI, whatever is available at home. Most of the our asthma patients are on MDI. So they all have spacer with or without mask. So we use a beta agonist, like Dr. Rashmi said, 4 to 8 puffs in one go, and then bring the child to the emergency. If the patient or at home the oxygen is not available, so yes, we can give nebulization at home also. At home, the management at home is totally different from what will happen in the ER and what will happen in the PICU.
Perfect, sir. Perfect. So, very important question I'll ask Dr. Rashmi, because this question is creating trouble in everybody's mind. So, is there a saturation cutoff to defining respiratory failure versus respiratory distress? When do you say it is respiratory failure? Because asthma says it is less than 92, bronchiolitis says 90, ARDS says 92. So what is a clear take-home message for students without
Yes.
a disease, severe type of disease? What is the saturation cutoff?
First of all, we have to remember that whenever you are managing a child, it is not a single parameter that will decide your kind of first line of treatment. Okay. So it is a combination of findings. Like, what is in the history? Is it the first time the child is presenting, or there is an underlying disease that has exacerbated? Because if the child is already having some problem, so he will tolerate a lower saturation. But if the child was perfectly fine, a sudden one, he may not tolerate a lower saturation. So that's why there is a confusion between this 90 and 92. So for all practical purpose, please remember 92 should be the cutoff. Exception is bronchiolitis, in which 90. But again, that 90, 92 is not a very big thing. It is rather a progressive decrease in saturation. Suppose if now you tell me, suppose it is 95. Are you going to sit quietly? No. Because you have to continuously monitor. Suppose it becomes 94. So decrease in saturation is also important. So not a single value. You have to see the serial value, what is happening, see the child. Do not get biased by the only saturation. And if you want to remember, please remember the cutoff 92, exception in bronchiolitis. But if you want also, you can remember for bronchiolitis also. If you want, okay, I want to keep the single. So 90 you cannot remember for all the one. So take it as 92 as the single one. But again, my request, see the serial levels so that you can monitor and see for the other features.
Perfect.
Can
Perfect.
I-
The message
can
is
I
totally
add-
clear. Yes, sir. Yes, sir.
Maninder, can I add something?
Yes, sir.
I think we should not go about the numbers. Look at the patient. If the patient is maintaining saturation of 94 with a respiratory rate of 60 with chest intercostal retractions, what is the game?
There is no
Your
point.
child is in respiratory
agree.
failure.
Yes.
So don't go only on number. Look at the patient. The clinical sense has to be there.
Yes.
Maintaining
Agree, sir.
saturation 94 doesn't give you time to go for a coffee. With the patient who is huffing and puffing, but maintaining saturation of 94, it doesn't make sense.
Correct, sir. Correct. Sheikh, sir, you want to say something?
I wanted to highlight exactly same thing what sir is telling. There is
Perfect.
general perception, oh, saturation is good, all is good. That saturation is at the cost of increased work of breathing.
Yes, sir.
That's
Correct.
extremely
Correct.
important. I mean, I have seen people not giving oxygen, sir, even after work of breathing because saturation is good.
I got it,
That's
sir.
not the
Point is
point.
very well taken.
That's not the point. The point is the increased work of breathing.
Yes.
That's very important. And second thing, number, that's always been 94, 92, 90, and 88. I think we should not tolerate anything below 92.
Perfect.
That's, I think,
Perfect.
that's what one thing.
Clear, sir. Clear
I
message is
totally
clear.
agree with what sir has said is that it is increased work of breathing. That oxygen is maintained at the cost of increased work of breathing. That we have to.
And one last, one more question to Dr. Rashmi only I'll put. What is the dose of 3% saline at
Yeah.
what hourly interval and when do you stop it for
Yeah.
bronchiolitis?
So that is a very good question. Please remember again, the studies have found that 3% saline offer marginal benefit in particularly moderate to severe cases when you feel that the child may require some intubation or may require shift to PICU. So next question is dose. The classical dose is 3 to 4 ml. Why 3 ml? Because that is the minimal nebulization dose. And please remember, many people administer 3% saline without a prior nebulization of this acetylene, bronchodilator. So 3% saline, it can paradoxically cause bronchospasm. Okay, so it will provoke bronchospasm. So to be on safer side, what we do, whenever we give 3% saline, usually we prime with a dose of nebulization. Otherwise, already the child respiratory, this one is compromised. So if you are going to give 3% saline directly, the patient may throw a bronchospasm. So you might have seen that after giving 3%, some children, they worsen for some period of time, or they may kind of may develop increase in symptoms. So that might happen. There is a risk. So better to give Asthalin followed by 3% saline. How frequently you have to use? So again, the question is that is not clear. So if you want, you can use like, let's say, maximum up to 4 times, but not more than that. 3 times is classically what is advised, but maximum up to 4 times if you want, the patient is responding. So that is based on our treatment of our mucociliary diseases, in which we use like 65 versus PCD, Asthalin followed by 3% saline 3 times. But if the situation demand, maximum to 4 times, not more than that, and better to pre-medicate with this Asthalin actually. And till how many days? Once the acute phase is over, you can stop it also. Okay, contrary to your mucociliary clearance, in which you have to continue longer. So this is just to tide over the acute situation. Maybe
I'll double cross question. I'll be the devil's advocate. So in bronchiolitis, do you follow the same? You give Asthalin followed by 3%, or you give alone 3% in bronchiolitis?
So that is the problem, sir. There is no study. I also debated in many forums, because 3% saline may it causes bronchoconstriction. All of us know. Okay, so that means you are paradoxically this one. So we don't know which type of case we are dealing. The child may be having some underlying asthma, and all of us know the first episode of wheezing is also mistaken as bronchiolitis. You might have seen that in your experience. You give a dose of salbutamol, the patient will respond. This happens also, sir. Like 6-month baby presenting, he's not responding. You give salbutamol, he's responding. We have seen cases also. So
perfect. So I'll cross question to Dr. Anil also. Sir, do you practice the same?
First of all, 3% is only in when the child has a moderate to severe bronchiolitis, not in the wards. Second is, yes, I will agree with him, Dr. Rashmi, that if we are using 3%, then a prior neb of beta agonist is desirable, so that we do not, inadvertently create problem for the patient, cause bronchospasm. But again, there is no robust evidence in favor of 3%. There is no robust evidence in favor of 3%. Similarly, as he rightly mentioned during the talk, give 1 dose of salbutamol. If it works, you continue. In such patients, I suggest that you go into the details of the history and ask about the family history of asthma. That's very, very important. If the family history of asthma is there, the sibling is on regular nebulization, or the father or the parents are asthmatics, then there is a scope to use beta agonists regularly in cases who are presenting as bronchiolitis or as a first episode of wheezing.
Perfect, sir. Perfect. Sir, I now ask very tough questions. So we have a patient of viral RSV pneumonia, adenovirus pneumonia, and all these new viral pneumonias that are coming, metapneumovirus. So what is your take-home message for the people? Should they give steroids? Yes or no? We want a clear answer, sir, for these type of pneumonia. Anil, sir.
Of course, this is a difficult question, because there is no one answer to treat all viruses. Like in adenovirus, if the patient has come to the emergency or in the PICU and is a severe case with multi-organ problem, then definitely I would like to give IVIG along with antiviral. But if the patient of RSV is there, first time episode, no high risk factors, no congenital heart disease, no kidney problem, nothing, it is only supportive, and high flow nasal cannula is my first choice to treat this patient with hydration and comfort. That is all I will do. Influenza, yes, if they are coming, we use antivirals in all these patients who are coming to emergency, or even in the ward, if they are getting admitted with simple oxygen by mask, we are using antivirals in these patients. Metapneumovirus, there is no particular treatment. As far as RSV is concerned, we are using ribavirin oral in moderate to severe cases, not in mild cases.
Perfect, sir. Thank you for the clarity.
Steroids ka role is very, very doubtful in all viral infections.
Done, sir.
It's
Thank
doubtful.
you. Now tough question for Dr. Sheikh. Sir, role of nebulized mucolytics like NAC, role of 3% mixed with adrenaline, role of lignocaine nebulization for irritant cough. All to Dr. Sheikh, sir.
Well, we'll come one by one. Number one is
Nebulized NAC.
yeah. For all this, there is no clear-cut evidence. Most of them are practice-based. So I think we will go case-to-case basis. If there is thick viscid secretions, then only we use about the NAC. Otherwise, no. That's number one. And along with the NAC, I will focus more on the other things as well, which includes your hydration, adequate hydration. That's important, and the other measures to take care of secretions, thick versus thin secretions. So the role of NAC is there on the case-to-case basis. That is thick secret. Otherwise, no generalize for NAC. Number one. Number second was what?
Nebulized lignocaine.
Lignocaine, so we have never used. I mean, I have never used, and there is no evidence for that also.
And then, sir, mixing of 3% saline with adrenaline.
No mixing of medications altogether. If you want to
Okay,
give just individual.
Now there's some jugaad which is coming for Dr. Rashmi. They are saying, why not mix 3% saline with Astelin and give it?
There is no point because your frequency, everything is different, and you don't know what you are mixing. So better not to mix. As I told, better not to mix any medication unless they are prepared by the pharmacy, like some company. Suppose it is a tested combination like Diolin. It is okay sometime, but we should not mix it.
So many people are mixing Budicort with Astelin.
The major problem is, as rightly said by the Rashmi, is that there are two things. Number one is frequency, number is dosing. So it may not match altogether. The fixed drug combination always have this problem. So mixing is always not desirable.
The one
volume will
answer.
be too much. Dr. Maninder, the volume will be too much. 3 ml of 3% and 2.5 ml of salbutamol. So 5.5 for half an hour, the patient will be on
And Anil sir, what about Budicort and Astelin, sir? Budicort and Levolin mixing, sir.
Budicort and
Levolin, sir. Mixing of Budicort
and Levolin.
Yeah. You see, we are talking about acute, then there is no role of mixing all these things. One should use individual drugs so that you assess the response. So there is no question of mixing.
Sir, even if
it is better to use individual drugs.
Yeah, sir, even if it is mixed, the frequency will be changed. The dose will be changed.
Sir, another point, budesonide is not used in acute asthma. Then why we are worried about mixing budesonide and Astelin? I don't know. We are not using Budicort nebulization. So
I think we should discourage these practices, Maninder, altogether. From at least.
Yes, I know. So we are asking, the students are asking. So they are saying that we are not going to give Budicort when we are giving IV steroid. Am I right?
Sir. Yes.
Okay. So there's one more question to Dr. Sheikh. They are saying if you're giving magnesium, one single dose, is there a role of measuring magnesium level in blood? Or if you want to give after the second dose, should we measure after third dose? What is your unit guidelines, sir?
Generally, it is not recommended to measure. So we don't measure. We don't measure. We see the clinical response.
Until unless you're giving an infusion.
Yeah.
Okay, sir. Dose, I think so. Everybody's after steroids in this whole Q&A. I think so.
Okay. Magnesium, I think all of us will agree. Maninder, the magnesium you don't give as a bolus like a syringe. You always give it over 15-20 minutes.
30.
So it is always infusion pump.
Yeah, sir. We follow 30-30 rules. 30 milligram per kg over 30 minutes. That is what
that's what I'm saying. You need to give over some time. You don't give it like a bolus, like a syringe, fill the syringe and give magnesium. You don't do that.
And before we close, sir, two more questions and then we close. The first question is to Dr. Rashmi. Ultrasonic nebulizer versus jet nebulizer, one line answer.
No difference.
No difference.
Whatever is available.
Whatever is available.
The last question to Dr. Anil sir. Cough syrups in pneumonia, what is the role?
No. My answer is no.
But parents are asking for cough syrup. What should we use?
Just convince them there is no role for cough syrups.
Done. I think so. I'm really thankful for the very clear messages that were given by our moderators. A very clear talk given by Rashmi. I know the questions were very tough because there are many gray areas. I hand over to Dr. Meena to please carry on with the proceedings.
One question I want to ask. One. Okay, oral Livolin versus the inhalational or MDI Livolin.
सर
Sir,
ओरल
it
का
is-
कोई रोल नहीं है.
Okay.
MDI or nebulized, either of the two.
Yes, sir.
Okay. That means कि oral suspension Livolin is useless.
Acute
No,
setting
no.
में कोई रोल नहीं है सर.
Acute setting में कोई रोल नहीं सर. Even in the office practice, it is not desirable.
Not desirable.
Second is that a lot of combination drugs are available in the market. Clonfenazine, Ambroxol, phenylephrine, and there are so many things which mostly we don't know the doses also, but we are writing as per the age and weight only.
डॉक्टर दिनेश, ये कॉम्बिनेशंस
Yes.
की बात ना ही करें तो अच्छा है. वो पिटारा है,
Yes.
खुल गया तो मुश्किल हो
Yes.
जाएगी.
And recently we had two news in the market. There are few deaths of the cough syrups.
So don't use cough syrup, no. We are saying don't use.
Okay, great.
Sir, please, just I want to add one point, like in the previous discussion regarding the dose of hydrocodone we are discussing. So the take-home message should be, as sir was telling, up to 5 you can use, because prednisolone dose is 1 to 2 milligram per kg. So 2 to 5 milligram per kg per dose, 6L you can use in acute setting. So that I want to clarify. The participants should not get biased that, okay. So that it is variable, so it is up to you. 2 to 5 you can use.
As I said previously, that we used to, during my residency, the hydrocod was the only thing which was available to us in the emergency. So it was like 5 milligram per kg per dose every 6 hours.
Yes, sir. You
We
can use
used to do earlier, as you rightly said, sir. I mean, maybe wrong practice, but we used to do 10 milligram per kg loading, followed by 5 milligram per kg per dose. But it has come down to lower dose now, sir.
One
And-
should not be afraid of using steroids at an early stage.
Yeah.
And so no role of antihistamines. They are saying no role of cough syrups, and
Nothing.
message is extremely clear. Over to Dr. Meena.
Sir, I have the small question. This one is the best platform to take the conclusive statement. What is the role of the cough syrup in the dry spasmodic cough, especially in the toddler age group?
Can we use honey and tulsi?
No, no.
Honey,
Yes, you
honey.
can use. Yes, I do prescribe honey, ginger honey. I do.
Sir,
Do we have the right to prescribe the Ayurvedic drug as a
No,
allopathic?
not
No.
Ayurvedic drug.
No,
It's
sir.
a home remedy.
I have no
Home
idea.
remedy.
No,
No,
sir.
home remedy you can use. No Ayurvedic drugs. Don't
but
label any.
is there any studies for that?
Yes, sir. Honey study.
Ginger and honey, is there any studies for that, scientific studies?
Sir, honey ka hai. Honey is there. Ginger, I don't know. So honey is, ginger may be there, but honey evidence is there that it
I think
is
Dr.
help in acute
Vivek
viral
Devan
kind.
Dr.
Sir.
Vivek Devan made a study on tulsi and
Does any role of the cough suppressant for the dry cough?
Sir, we must understand the cough is a protective phenomena.
Okay, dry
And
cough.
the best
What-
thing is that, the best cough suppressant, what happens when you have a cough? You go and have a small sip of water.
Yes.
ठीक है
I
sir.
mean, generally, it is
And one
designed
more
to
important
not-
thing is, there
sometimes
are a lot
there
of
is-
types of cough, like autogenic cough, like psychogenic cough, like
I think we
Okay,
can have a
many.
separate session on
We
cough.
got the
not
clear-cut
in this.
message. Try to avoid the unnecessary prescription of the cough syrup in the chain.
Yes, yes.
And number
That
one
is
important
expert
thing, sir,
message
treat the cause of cough. Treat
Exactly.
the
Yes,
cause of cough
yes.
rather than the effect of cough.
So I would like to conclude this today's session. Thanks, Dr. Rasmi, such a wonderful, informative, lucid talk. Definitely, after this talk, our resident or practitioner will get the benefit. And I would like to thanks to, as usual, Dr. Anil Sachdeva. कहते हैं ना जान फूक दी प्रोग्राम में और एक्टिविटी में यू आर द वॉट एवर कंक्लूसिव स्टेटमेंट फॉर द each and every questions you give the valuable inputs, and thanks a lot to Dr. Sheikh for the such an important clarification about the 3% as versus ethylene, dose of the dose of the hydrocortisone, and role of the dexamethasone. Preferably not a good, but whatever if the not other hydrocortisone steroids are not available in the emergency, then we can use the dexamethasone at least कुछ नहीं तो कुछ better सही. So definitely I would like to thank to all our chairpersons, speakers, participants, and our dear friend Dr. Maninder is the brain behind the successful of this program. And I would like to thank my all Delhi IP executive board members or technical persons, Sushilji, they work behind of this program. Over to our treasurer, Secretary General, Dr. Dinesh. You the
For
some.
that, I'd like to invite everyone for the Pet Alercon being organized on 11th and 12th of October. and also Pediatric Conference of North India next year in June 2026.
Great. Thank you, sir. And it's a wonderful session and clearing many confusions. And now we are with more thoughts. And it's always to have a good session so that whatever we are doing, we can correct ourselves if we are doing wrong. The attending the session is important just because of that, because we are doing many things without evidences also. So, and with the, you can say our own training part, because whatever we are got in the training from our seniors, that we are follow. But to correct to modify that thing which we learned in past, it's little difficult, because at this age the reception of the mind is is difficult. But it's a wonderful session to have the Dr. Anil Sachdev sir, Dr. Sheikh sir, and speaker Dr. Rashmi. He is the national coordinator for the code module also last year. And with this, thank you so much, sir. And we will have a few more sessions in future. Thank you.
Okay.
Thank you.
Thank
Thank you,
you.
everyone.
Bye bye.
Good day, sir. Good morning, sir. Bye.
Bye.